Hello, Facebook Live. This is Bill Bird. I'm the Chief Medical Officer at CGH Medical Center. And welcome to our chat with one of our medical staff. I'm happy to have today Dr. Ashlea Canady. Hi, Dr. Canady.
Hi there.
Yeah, I'm glad to have you. Dr. Canady's a general surgeon here at CGH. And this is the first of our, we've had other surgeons on, but Ashlea is our first general surgeon we've had on. So looking forward just to kind of having you learn a little bit more about her and what it is that she does every day to day, right? Right, so and by the way, obviously as we're doing our having our conversation, please send in questions to us and we'll answer those as best we can. And kind of like I did last time, I'm gonna have Dr. Canady ask her some questions, and as you send in questions, if I have any questions for her, we'll ask those. And then once we're done with that, then we'll kind of get a little more into COVID and talk some COVID stuff and what the latest is and what we're seeing here in our community, in our county, in our state, those type of things. So with all that being said, Dr. Canady, I ask all my folks this because it's always fun to hear stories. So tell us your story about what got you from St. Joe Ogden to deciding you wanted to get into medical school and then you wanted to be a general surgeon. So tell everybody how that one played out.
Sure. So it was actually my advanced biology teacher in high school, Mrs. Kitzman. She recommended that I attend a National Youth Leadership Forum on Medicine because she knew I liked the sciences and math. And so I went to this conference and camp, and we got to pretend that we were resident physicians, and we got to problem solve and learn about different diseases and go to an anatomy lab, and that's what solidified that I wanted to go to medical school. And then when I got to medical school, I was not planning to be a surgeon. That was not anywhere on my list. A family practice doc.
Hey.
Yeah.
That's a noble calling as well.
And I liked it. But then my first rotation as an M3 year, and that's typically when you start doing your clinical rotations, that was surgery, and I fell in love with the operating room. I would take every opportunity to be in the operating room.
What did you like about it?
Just the teamwork and the problem solving right then and there. You fixed that patient right then and there, and you saw immediate results. My husband and my mother always knew when I was in the operating room that day, I would come home with the biggest smile on my face.
Okay, there you go. M3. So folks, what does M3 mean? So
M3 is your third year of medical school. Your first 2 years of medical school are usually book studies and lectures. And then starting your M3 year, your third year, you start doing clinical rotations with actual patients. So it's really eye-opening because it's not just test questions anymore. You're actually having lives in your hands.
And for most of us, that's kind of when we make that call about, okay, I want to do this or this.
Right. You get to experience the core areas of medicine and then get to decide what you want to do.
Yeah. You know, that I haven't heard of that, this leadership forum thing before. Is that still going on?
I don't know, to be perfectly honest with you.
All right. I mean, that sounds like that's a smart thing.
It was an amazing opportunity.
Yeah. Okay. Yeah, that makes sense why you do that. What else, before you decided medicine, what else were you considering?
I wanted to be president.
Okay. Well.
But then I learned I really don't like politics.
Oh, okay.
My mother was a debt collector, and so I grew up around attorneys and lawyers a lot. So that was definitely on my short list too. However, I learned I don't like to argue that much either, so that came off the list pretty quickly.
Okay. All right. Interesting. Okay, good. And then general surgery. That is I think it's a 5-year deal.
It's a 5-year residency program, and then you have the option to do fellowship afterwards.
Okay. So, you did Peoria? Is that where you
did? I did University of Illinois at Peoria.
Okay. All right. So, that's pretty rigorous.
Yes.
Tell us about that.
So you're at the hospital at least 80 hours a week. I mean, 80 hours a week, if anybody from that board is listening. And it's 5 years of hard work like that, and you get more and more clinical responsibility as those 5 years go on. University of Illinois Peoria is a unique program where they actually train general surgeons. They are not training you to go into fellowship. That being said, if you want to go into fellowship, they are very competitive to get into the best fellowships, but they actually train you to be a good general surgeon right out.
Yeah. So Dr. Canady alluded to this 80-hour thing. Like when I was going through residency. Oh, okay. We need to speak up a little bit. When I was going through residency, there weren't any hours per se that were set on how many hours residents could work. And particularly for a lot of our surgical specialty folks.
They were living at the hospital.
Yeah, yeah. And, I think there's it was probably the right thing to do to put some sort of structure to that. I don't know if I took 24 times 7, I don't know what that is. But anyhow, it was a lot of hours a week that people were spending doing that.
Well, and thankfully, they have realized that the work-life balance is more important now, and it's not just about work. You need to have other activities outside of work. So they're starting that with residency.
Yeah. What are your activities? That wasn't on my question.
I was going to say, that wasn't on your list of approved questions. No, I really enjoy gardening. I do not have that green of a thumb, but I am working on it. And cooking. My husband and I cook together almost every night. We like to do that a lot.
I remember you saying you were a musician too, right?
I was.
Okay.
I need to get back into it. But yes, I played through college.
What did you play?
I played piccolo.
Okay, so if anybody's looking for a piccolo player in a band.
I don't think you want me yet.
Okay, good. And the other thing I wanted to ask you about the surgical residency stuff is what made you decide that you want to do general surgery versus
a subspecialty?
I don't know what percentage of folks go into subspecialty surgical care, but it seems like it's a decent number these days.
It is a decent number. So I love general surgery because of the variety of cases that I get to see. But specifically why I didn't go on into a fellowship to do a subspecialty is because I knew I wanted to serve a smaller community, and frankly there's not that many opportunities for those really nitty-gritty subspecialists in a smaller community. You need to be in a larger facility. You need the larger facility to accommodate all the different surgical procedures that you do. And so I knew that's not the track I wanted to take. I wanted to be with my community, so I stuck with general.
Yeah. We're glad you're here.
Thank you.
And speaking of community and community hospitals, I wanted to give you a chance to kind of speak to what is the wheelhouse of a general surgeon in a community hospital. Can you speak to that a little bit?
So a general surgeon is trained in all areas of surgery. We do not do a lot of training in orthopedics, but depending on what location you're at, you may need training in orthopedic surgery if you don't have that opportunity. I'm very thankful that we have those people here that I don't have to do that. So we do everything from the head to the toe, though. We commonly do thyroid surgeries, we do lung surgeries. The most common surgeries we do are gallbladder and hernia. We do colon surgeries, cancer surgeries, breast surgeries, little lumps and bumps. I'm sure I'm missing quite a few.
Yeah, and like folks, melanoma.
Melanoma, yeah.
Yeah, so some of these wide margins is what they call them for melanomas. Yeah, I mean.
We do just about everything.
Right, right. So yeah, there's not I would say a little bit of the chest stuff you all do, but not tons of it.
Correct. We do lung surgery, but not humongous lung surgeries.
Yeah, okay, good. So yeah, most of the things that come in through the emergency department or the office, Dr. Canady and her team take care of. What did I hear? Was it like 50? This is interesting about general surgery. Is it like 50% of the work that you do, of the surgeries you do, you don't know about prior to that week?
Correct. Yeah, usually it's about a week in advance that I actually know what my next week looks like.
Yeah, because someone comes in with a hot appendix, or their gallbladder is acting up.
Exactly.
Yeah, okay.
And thankfully here, we're able to get people in very quickly to general surgery. So if our GI team scopes somebody and sees a cancer, they can get into our clinic usually within a couple days, if not the next week, to plan the next steps.
Sometimes I've heard that like our GI docs will scope somebody, they have a cancer and they're already bowel prepped, and so like they will even do the surgery.
Occasionally,
Yeah.
occasionally.
You
I
usually wait these
personally
days?
wait because I think it's important for the patient and the family to have a complete understanding of the surgery.
Ah, okay.
And usually
Okay.
that's a lot to process to get that diagnosis and then say you're having surgery the next day.
Okay, so maybe that's maybe a little more of the old school way.
It's surgeon preference.
Yeah, okay. Hey, this is a real positive one. It's not a question so much. It's from someone who says that Dr. Canady saved my life not once but twice.
Oh.
Greatest surgeon of all time.
Thank you.
I'd give a name out, but I don't want to.
Yeah, for sure. Thank you.
So, yeah, good. I think you kind of alluded to it, but what would you say the favorite part of the work you do is?
Oh, it's the variety. It's not knowing what's coming through the door. I love having the spontaneity of what my day is going to bring.
Okay, so if your belly's hurting really bad right now in the right lower area, you got a little fever, Dr. Canady really wants to see you.
I need my third appendix of the week. They come in threes. I only got 2 this week.
Okay, all right, there you go. So, all right. And I know, one of the things surgery related, can you speak a little bit to what we're trying to do and this isn't one of my questions that was on here, but you're good, you can do this. So speak a little bit to what we're trying to do to help people get home sooner and need fewer pain medications after their surgeries these days.
So any surgery that we can do what's called minimally invasive, meaning with smaller incisions, we try to do. And there's a couple different protocols that we can follow. One of them is called the ARIS protocol, and that is enhanced recovery after surgery. And so there are a list of protocols that other facilities have experimented with to try to get people to recover quicker. And that includes trying to avoid narcotics and using non-steroidal anti-inflammatory drugs instead of the narcotics. And honestly, it's very effective. I frequently do colon surgeries, ginormous colon surgeries with tiny little incisions.
That's a medical term, by the way, ginormous.
Yes, that's right. With tiny incisions. The biggest incision I make on the body is usually 4 inches long, and that's actually to take the colon out from, so I'm not in that incision for very long. And my patients routinely can handle the pain with only Tylenol and ibuprofen. So it makes a big difference trying to do things with a minimally invasive style rather than what's called maximally invasive surgery, which is a big incision from stem to stern.
You're a young surgeon, Ashlea. Was that going on even in your residency, or has that been a change even since residency, some of this stuff?
I was primarily trained to do minimally invasive surgery. That was the majority of my cases.
How about the pain medicine stuff? Is that also?
That has changed since I've been in residency. In residency, we gave out narcotics very frequently, and thankfully we're adopting the new practice of trying to avoid narcotics. It significantly decreases the hospital time because people aren't getting what we call an ileus, meaning that their guts fall asleep, and that's due to the opioids.
Yeah. Well, I can remember back in the day, I mean, people would sit and sit
Yes.
and sit in hospitals, that was just what people did.
Yes.
Yeah, so
Not anymore.
No, you see, when you're on the surgical floors now, quite frequently you see patients making their rotations around the unit just to kind of get their
intestines moving. That's right.
Yeah, good. I want to pivot to some stuff about the pandemic. So what would you say has been your biggest challenge during this COVID stuff?
The uncertainty, for sure, and prioritizing patients. I had a lot of patients scheduled for surgery that we had to call and talk about, do we really need to do this surgery right now, or can we wait until it's safer in our community to do so? But just not knowing week to week what our numbers are going to be and what different things we can do to keep our community safe was the biggest challenge, for sure.
Yeah, kind of triaging and picking.
Yes, yes.
What's your biggest concern right now with all this?
Honestly, it's the increasing numbers in our area. And when I'm out and about at the stores, seeing people not wear masks and not take this seriously. The mask isn't just for yourself, it's to help protect the other community members around you.
Yeah, for sure. And then it even affects some of this stuff. The increased cases affects the surgery side of things in terms of getting our test results back. Do you want to kind of talk about that a little bit?
Correct. So we've had a delay in getting our test results back because we've had having to test so many people. Before any elective surgery, we are doing COVID testing to make sure that our patient is negative. This not only protects our patient, but our staff from getting exposed. And we've had several surgeries that needed to be canceled because our patients turned out to be turned out to be positive with the COVID testing. And we needed to protect everybody involved.
Yeah. Yeah, so that whole across the country type of situation here in just a little community hospital, CGH, has an impact in terms of some of those kind of things.
Definitely.
Yeah. Yeah. How's the flow of patients going in your office?
It's going really well. We're back up to full office. I've been very impressed with how they're moving the office along and trying to limit how much time people are spending in the waiting room, trying to limit the patient-to-patient interaction. Our staff is doing an awesome job cleaning the chairs after patients, cleaning every room after patients. We're just really focused on keeping things as clean as possible and enforcing mask use as well.
Yeah. Yeah, it's an ongoing thing just to kind of make it part of the rhythm of how we do things.
Yes.
Yeah.
Yes.
Yeah. It is, for sure. So I think I know earlier on you alluded to that surgery tends to be, you're the captain of the team.
Right.
But it tends to be a team sport, and I just wanted to, can you talk a little bit about your team and some folks that help to kind of make everything work the way that it does? For
sure. So you know that phrase, it takes a village to raise a child? Well, it takes a village to raise a surgeon as well. Mm-hmm. So we have, starting in our clinic, we have our receptionists that make sure the patients are remembering their appointments and getting their everything, all the testing done and everything like that. We have, each of us are very lucky, each of us surgeons have our own personal nurse, literally our right hand. They do all our clinic work for us, they do all the scheduling for us, and then they come with us to the operating room and are able to assist us in surgery. So thank you, Angie. And then my partners, of course. I have 3 awesome partners, Dr. McGlone, Dr. O'Halloran, and Dr. Wakefield. And we all work as a team too, especially on those larger cases. It's nice to have a second set of hands that have done the surgery before. And then we have our pre-op nurses who get the patients ready the day of surgery, make sure all the T's are crossed and I's are dotted. We have our OR staff, which includes our awesome anesthesia team right now. They are great, they're hardworking. We have our nurses back there and our surgical techs back there too, that they're often the unsung heroes. They're the people that you don't remember because you're going to sleep, but these ladies work their keisters off trying to get everything prepared and make you have the safest surgery possible. And then our recovery nurses too, again, oftentimes not remembered because you're coming out of anesthesia, but they're the ones by your side when you're just waking up and you don't really know what's going on, and they're giving you that comforting touch and making sure your pain's controlled.
Yeah. I in family practice have not been one who's been, I was around the OR during my 3rd and 4th years of medical school and a little bit in residency rotations, but having been away from the OR for 20 years, I was struck again as I've been more involved with that as a CMO, how much it is this community within a community.
It definitely is.
Yeah, yeah.
We are very close.
Yeah, it's very much a different world.
If one part isn't working at their utmost potential, then it's affecting everything else.
It does.
Yeah.
It does. So yeah. Good. I'm sure there's some other questions that I'm not thinking of. As we've been talking, anything else come to mind that you want to share with the folks that are listening or will be listening sometime later?
Sure. Things in the future is we are hopefully going to get a robot here at CGH. I don't know the timeline on that yet, but that will enhance our ways to do more minimally invasive surgery, so that enhances your recovery time and your length of stay in the hospital will decrease too. So that's in the future. It's in planning, but not here yet. But that's something that we can all look forward to bring to our community.
Good. Well, Dr. Canady, it's been nice having you.
Thank you.
And I think I did all right
in terms. You did.
Yeah, Dr. Canady, she's I'm by no means some fancy talk show host, but if there was like, you know, today's talk show host will talk about a tough get. She was, Dr. Canady was kind of like, oh, and look, she's done great. So, you know, if you're on there, give her the thumbs up. She's doing good work, and we want to have her back sometime too. So
I'm definitely more comfortable behind my mask and in my scrubs.
We did great, and nice to have you. And
Thank you very much.
I'm gonna let Dr. Canady go about her day and take off, and I'm just gonna kind of touch on some. Go ahead.
Thank you.
Yeah, thanks. And touch on some COVID-related items that I just wanted to share. And before I do that, I also wanted to give a couple shout-outs. First of all, our Employee of the Month. I thought I should start letting folks know about our Employee of the Month. So Sue Hageman in oncology, she's a nurse navigator there. And what her job is to folks who have cancer kind of walk them through that process there in our oncology department. And Sue does a great job with that and was very deserving of the Employee of the Month award for July. So shout out to her. We have what's called a daily safety huddle. In the course of that, something came up about our case managers and social workers. And I haven't had a chance to mention them, and I just wanted to give them a shout out. So it's a relatively small department. So their manager is Julie, and then Lori, Julia, Sarah, Missy, Andrea, Chris, and Megan are all part of that department. So if you're hospitalized here at CGH, these folks are very involved in making sure that the services you need here, and particularly what you're going to need when you leave here, that they're working that through with you and with your family to make sure that as you launch out of the hospital, that is done successfully. And they also do some work while you're hospitalized and making sure from insurance standpoint that you're in the proper status and those type of things. So very essential, very helpful folks here in the hospital, so thank you to them. I wanted to make sure I did that publicly today during this Facebook Live chat. So I have some stats. Dr. Canady left. Let's see here. How long does the average colon cancer surgery take in the hospital? It says ER, but I think they mean the OR. I'm just going to throw out a number. I'm going to say a couple hours, but I'm not sure because I'm not a surgeon. But that'd be my guess on that. Sorry about that. I wish we'd have had that before Dr. Canady hit the road. Wanted to talk a little bit about some COVID stats that I have. So here's what I'm seeing today. Right now, actually on 7/22, there were 59,628 people hospitalized across our country, which compares about the same as what we had in April 15th, which was 59,940. So essentially the same number of people hospitalized. Not an encouraging trend. In the state of Illinois, the positive percentage of people that test positive, they're having testing done, is slowly eking up. It's still way better than a lot of states, but we're at 3.4% now. I think when I talked last week, we're around 3%. Illinois still is, by and large, pretty good as the states go in terms of the number of cases, but it has crept up a little bit, and I know you draw all the states around us, I think, not Michigan, but in Indiana, Iowa, Missouri, and Wisconsin all have a higher rate right now than we do. So I think maybe there's some carryover from that to us. So it's just a trend that we're watching. Now granted, Arizona's positivity rate is 25% right now, to give you some perspective on that. So we've done a better job as a state than others, but it's still, higher than we like. Our testing here at the hospital, our percent positive is 4.7% if you take the whole time that we've started testing. I think that's a little skewed because particularly early on, we were very selective in terms of who we were testing. And so I think that drove our numbers up higher than you would see for other places. You know, Whiteside County overall is doing pretty well. That being said, our number of, I think they do it, the number of cases per 100,000 people on 7/23 was 11 per day, 11 per 100,000 on the 23rd. Just to give you some sense of that, we were at 5.1 2 weeks ago, and Cook County right now is at 9.9. So if you take the number of people that we have in our county and run those numbers, we would be a little bit above what Cook County's rate is right now. So to Dr. Kennedy's point, it just goes to making sure that you do the smart things when you're out and about. So that I thought was just something that's sobering and just to be aware of. One of the things that the CDC just came out with in the past couple of days that I wanted to share with you too is isolation recommendations. So that's if someone is test positive for COVID, they need to self-isolate, they need to isolate. They're moving away from a testing-based model in terms of getting back into society and going to a symptom-based one where basically they want you to have been at least 10 days after the onset of symptoms, and your symptoms need to be getting better, and you need to be fever-free for at least 24 hours before you start re-engaging outside in the community. So that's a new thing. CDC just came out with something that I think is going to be very controversial, much talked about, I think it was last night, and that's their recommendations about encouraging the reopening of schools, just based upon some of the, based upon some of the stuff I've been reading. I think that's going to be pretty controversial. I think there's a lot of work still to be done in terms of schools and how that's going to be done in a safe way. Yeah, and then what else did I want to share? Oh, right now in our country, most of you know this, but just in case you're staying away from numbers, I'm going to share a few with you. We are now at over 4 million total cases and 144,200 deaths in our country. And still going. I think we're still in over 1,000 a day in the country in terms of deaths. So still very much a need to take this seriously, and in terms of when this is going to change and move in a different direction, I'm not sure. One of the positive things I was seeing is that, like the fact that they do this factor, I think it's the R factor, and that's how quickly things are spreading. And even though there's a lot of states that have above 1 R factor, including Illinois now, it's still lower than it was 2 or 3 weeks ago when I was looking at that. So, okay. Let's see what it says here, if we have any questions for all of you. Let's see here. How's the hospital doing with COVID admissions since we've had an uptick? Yeah, I think overall we're doing fine. We have had up until, I think I mentioned this last week, we had like 2 weeks or so where we didn't have anybody in the hospital with COVID, and then we've had a run where we've had people in the hospital with COVID, but it still has been doable. And we've had, what's been really nice is at least right now we have just enough rapid testing that if someone's going to be admitted to the hospital and we have concerns about them potentially having COVID, we're able to test them and know before they're admitted. So that makes a big difference in terms of the PPE we use here at the hospital and being able to conserve that and know where we're at in terms of taking care of folks. So that's been really helpful. We still, those are very precious tests, those rapid tests, and there's no guarantee that continues, but for right now that's been very helpful for us, and so I think we've been able to manage that quite well. Early on we had these bubbles here at the hospital where we kind of compartmentalized and had potential COVID patients in those areas, and because we're able to know when someone's admitted to the hospital whether they're positive or not, it's helped us to not have to have those bubbles, so that's been really helpful. All right, let me see if I have any other questions that have come in. I don't see any right now. I want to make sure I'm not missing anything that I wrote down. Okay, good. Well, once again, I think we'll call it a day here on our Facebook Live. Hope it was helpful. The information, Dr. Canady was great to have on here and hear what she had to say. And I guess we do have one more listed. So here we go. If I had some, I'd go to a commercial break if I had, but we're not. We're live. So maybe just tell me what the question is, because I'm not quite getting it on my, what's it saying?
I'm not sure how to pronounce it. Do you have remdesivir to use on select appropriate COVID patients?
Remdesivir.
Yes.
Yes, we do. We have it. We do have remdesivir. And let me see if I can pull that up. Okay. Yeah, we do have remdesivir. We have used it. We've also done some convalescent plasma on some patients. Yeah, I think in talking to our medical staff, we think it's helped some. Both those medicines aren't like you take it and then just boom, you're better. But it's nice to be able to have that and have that available for our patients. So yes, we're able to do that right now. I got a couple shout outs. Thank you, appreciate that. As we get closer to school opening stuff, I think we'll be talking about that a little bit more and what implications that has in terms of at least the hospital and perhaps the community as well. So those are the things I wanted to share today. Thanks for all of you for listening. Hope you have a great weekend. Stay safe. Follow all the precautions that everyone needs to do, and we'll talk again next week. Thank you.